Thank you for having a paused image, a nice paused image of that. So we'll introduce the case. This 73-year-old lady with C15, M17 Barrett's, never having had any dysplasia, last having follow-up in this reference center because the patient has got long segment Barrett's, so very long segment Barrett's, probably the longest you've ever seen. So the basics that the everyday endoscopist need to understand about assessing Barrett's. I would say go to the stomach, find the diaphragmatic pinch. Because let's take the measurements first, shall we? I mean, we've done an overview, we've looked, we didn't see anything major. There's food in the stomach, so we have to be careful, and it's not clear. That we'll just ignore for now. All right, find the diaphragmatic pinch. Here, right? Okay, so we have a cap on the endoscope. That means that we have to acknowledge that when we're doing our measurements. So let's exclude it, right? So the tip of the endoscope is a little bit off where the tip of the cap is. Don't measure where the tip of the cap is. So just come back and show people how you're doing this measurement. Come back, come back, come back, come back, come back, come back, come back. Okay, come back more. So we just get an overview, right? Come back more, come back more. Okay, so you can clearly see it in the distance, the diaphragmatic pinch, right? Now go in more. Now go into it where you think that it is. More, 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 more. Stop. Okay, I think that's where it is. Okay, this distance is?
I would say 39.
39 centimeters. So we found a diaphragmatic pinch. We're now going to try to discover the top of the gastric folds, right? So this is the next landmark you need to detect. The diaphragmatic pinch is back in here. Come back in the same orientation. Don't lose the orientation. See this hand? You can relax it a bit more so that you keep it like a bit more down here, right? You don't need to have it up in the air because that's quite a lot of stress on your hand. Okay, so keep coming back. Keep coming back. Okay, where is top of the gastric folds for you? Keep coming back. You need to see it entirely before we go further.
So maybe I freeze the image. We can see here at 6 and 4 o'clock 2 folds and
and so we'll point this out later on the review images when we talk about breaking it down. But yeah, I think you're right. You can see it in the middle of the screen. So let's try and measure where that is. So the top of the gastric folds is where you obviously kind of described itself. You no longer see gastric folds, but there are other appearances we know that come in that area. And what are they?
Palisade vessels.
Yes. So now let's characterize this based on acetic acid. How long are you waiting now?
How long?
I mean, say that there's nothing there now. Is that fine?
No.
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 I would wait.
No. So people have to wait like 40 seconds at least, right? 20 to 40 seconds is when you're getting these zones. So we're talking about ELAW, early loss of aceto whitening. You'll see this term used today a lot. There's a very important concept in Barrett's esophagus because acetic acid assessment is so good, so useful, so quick to interpret. Okay, so where do we start the biopsies, Michele?
I would start at the GOJ.
And where is the GOJ?
We have seen it pretty well with the top of the gastric fold and the palisade vessels.
So around about here, right? In this zone, okay. So I think that this zone, you can clearly see, if you really use the insufflation, you can clearly see, you can get the cap in there to really pull back on it. So this here, this is the GOJ, right? This is a GOJ. And you see the gastric fold ends here, but it's actually this zone which you're particularly interested in. And where is another gastric fold where we can demonstrate that? Here are these vessels up here, right? And here is the top of a gastric fold. Here, the biopsy forceps is very useful for pointing. Here is the top of a gastric fold. Okay, biopsy technique in the esophagus. I'm actually going to biopsy that zone, right? So you want two techniques. One technique for I want to biopsy something focused. That technique is following. You open the biopsy forceps. If you think that what you want to biopsy is smaller than this, you close a bit, but don't do it. We're just going to biopsy a big piece of esophageal mucosa, right? So the technique for that is find the target. Okay, so I'm still finding, I'm still in target seeking mode. I need to find this kind of area, right? Then, okay, this is going to get a superficial biopsy, okay? I've used torque to turn into the mucosa. I'm doing some suctioning. Suction is not high because we want your experience of this course to be really nice. But if you suction, you really use torque to turn in. Then we can close the lumen a bit, then take a slowly close. Then we can definitely take a piece, right? This is one piece. And if that was, take it out. If that was a thing we needed to biopsy, then this is the only biopsy in this set. We put it in a pot. Very important, targeted biopsy. Do not take 2 biopsies, because if you take 2, there's a 50% chance you lose the first one, right? Second thing is, then if you want to take blind Barrett's biopsies, which is what we're doing here because we saw nothing. So these are Seattle protocol biopsies, never any dysplasia.